My name is Jan Klaassen. I'm from New York, and I will be talking about coma and disorders of consciousness. These are my disclosures, so my federal funding and other work on books and things that I've done. I'm a minority shareholder in ICE Neurosystems. So to start out, you can ask yourself, what is consciousness? What is coma, right? So that's the topic of the talk. If you go back to like the fundamental books that started us thinking in medicine about this question, you go back to the Stupor and Coma, Diagnosis of Stupor and Coma book by Fred Plum and Jerome Posner, which was actually the first edition came out, I think, about the year when I was born. So please don't look it up, it's a long time ago. But what they have said is, if you think about consciousness, it's this awareness of self and the environment. And there is an important component there, that's the subjective experience and the self-report of mental representations. And I think it's important to think about what we define as consciousness, because if you look in the literature and you look at philosophers, for example, there's tons of different things that people talk about when they talk about consciousness. Some philosophers even think all of what we experience here, this conscious experience, is an illusion. And that may or may not be true, but what we think about when we talk about consciousness and coma in medicine is quite different. I think that captures it quite well. There's impairment of consciousness that is very, very frequent. You can just think about sleep, where people lose consciousness to a certain degree in a predictable way every day or most days. Some, like, people in the healthcare field less frequently probably, but people go to sleep and lose consciousness. And anesthesia people use in a predictable way. With general anesthesia throughout the world, thousands of people lose consciousness every day. And then what I'm most interested is in critical care and the relationship of brain injury to consciousness. So the concepts, there's different states, right? And this is a little bit tedious, but I just want to introduce this concept. So coma is the oldest term that actually comes from the Greek philosophers. They described it as a state of sleep where you could not be aroused from. And then the more recent concept, the vegetative state, came about in the 1960s by Teasdale and others and Janet, and they defined it as a state where patients open their eyes. They are not conscious where you can interact with them. They open their eyes. They have some sleep-wake cycles, but there's no evidence that they're conscious. So that's the vegetative state. They initially thought it was always a permanent state, so that's why they called it permanent vegetative state. But we know now that some people actually emerge from a vegetative state. The minimally conscious state is probably the most recent sort of addition to this. This came about in the 1990s or so, which describes a state where you're not fully conscious. So minimally conscious state minus, you just have eye movements towards the examiner, for example. You may track the person in the room, but there's no interaction. You ask the patient to do something, and they do not respond to that. Whereas in minimally conscious state plus, people intermittently follow some commands, but it's not sort of consistent. And then emergence is emergence out of these states of unconsciousness. Locked in states are patients that classically have a disorder where they have an injury to the pons, so the brainstem area, and they are fully conscious, but they cannot express this with their motor responses fully. They can often move their eyes and communicate that way. And then recovered is basically recovered. So let's take a step back and think about what are neuroanatomical models that we think about when we think about consciousness. When I was in medical school in Germany, I thought all of consciousness was just the reticular activating system. That's what mainly people talked about. So the ascending arousal system. And that's very, very important. It's mostly about arousal, though. So it's only part of consciousness. And we know now a lot from studies by Cliff Saper and others that have identified neurotransmitters where you have centers in the brainstem, for example, here in the pons, that project upwards, some through the thalamus, others extrathalamic to the cortex, so to the upper part of the brain. And that's sort of most of the arousal. Then you have these basal ganglia circuits, which is best conceptualized by Nico Schiff's group. It's called the mesocircuit, where it's a sort of feedback loop. You have some areas, the central thalamic nuclei, they project to the cortex, they get inputs from the lower brainstem areas, and then in a feedback circuit via the striatum and globus pallidus, so these are basal ganglia structures, deeper structures in the brain, there's a feedback loop on the central thalamic nuclei, and that is very important to consciousness. And then last but not least, there's the global workspace theory. This has been probably best conceptualized by Dehaene in Paris, his group and others, and where basically you can think of it where you have all these inputs, and how is this conscious experience that we all perceive put together. So think about you're lying at the beach and you're not perceiving it as grainy sand or graininess and bright and warm, and you experience that I'm at the beach and I'm having a good time. And how is that all conceptualized? So this is a mathematical model that was put together to conceptualize the idea peripheral inputs, long-term memory, sort of attentional input, and then motor expression. If you think about what kind of injuries cause impairment of consciousness, because the talk is about consciousness and coma, you can think about diffuse injuries of the cortex. Think about a cardiac arrest or hypoxic situation where you have a diffuse injury of the cortex that causes unconsciousness. But it's not that only huge lesions cause unconsciousness. You can have very strategically placed lesions in the midbrain, for example, here, that make you unconscious, or even in lower brainstem areas. And those are sort of areas that typically are associated with disorders of consciousness. So how do I approach an unconscious patient in the emergency room? Most importantly, it's ACLS, right? So if your patient is not breathing and doesn't have a blood pressure, it doesn't matter what the disorder of consciousness is, the patient will die. So it's very, very important to think about, never forget that. And all of us work in hospital care settings or in healthcare settings where this is protocolized, but it's important to make a point of that. And then at the same time, identify rapidly the most likely category of pathology that's underlying the disorder of consciousness. And if I do that, sort of the way I approach it is based on the Plum and Posner book. The newest edition came out in 2019, where etiologies are categorized into big groups. So you can think about supratentorium, so the tentorium separates the upper part and the lower part of the brain. Supratentorial structural lesions. That is, for example, a bleed up in the brain, or a big stroke there, right? So they think about supratentorial structural lesions. Think about infratentorial structural lesions. That's, for example, in the cerebellum, a hemorrhage there, or in the brainstem. And then metabolic non-structural pathology. That can be anything from infections to sepsis to hypoglycemia. The most common, if you encounter anybody in the emergency room, statistically about 65% of the patients will have metabolic non-structural pathology. So if you want to play just a betting game, that's the most likely. But there are things on the exam when you encounter the patient that point you towards one or the other category. So if you have, for example, somebody with focal findings, then very focal findings, it is more likely to be a structural lesion. It doesn't need to be. You can have a focal finding, which is, for example, a plegia of the arm, also in patients with hypoglycemia, but it makes it more likely to be a non-structural lesion. If you have somebody that has a very low blood sugar, obviously you've made the diagnosis, and that's a non-structural lesion. There's rarely psychogenic causes that can be encountered as well, and if you've had that, it's very, very disorienting because for the physicians or the healthcare team, because these patients may allow you to put lines in, central lines, all sorts of things, but they have a psychogenic cause of coma. It's rare. Often EEG helps there quite a bit because you can see that they have a normal EEG. But why is all this important? It's not just an intellectual exercise. You want to target your initial therapy towards the most likely cause, underlying cause of your coma. So that's why we do this. So targeted therapies. The initial management is standardized. There's nice sort of paradigms developed by the ENLS, Emergency Neurological Life Support Systems. They're actually for free online available. You can just Google it. And if you look at all this approach, That all has to happen at the same time. So, but this is actually how we handle most things, right? If you have somebody with a cardiac arrest, somebody does chest compressions, but another person stands back and thinks about what's the cause of all this. And the same approach should be used for somebody with coma. I'm an intensivist, so most of the time when I encounter patients with coma, it's in the intensive care unit. And why is it important for intensivists to think about that? Unresponsive patients are very, very common in intensive care. Just think about the level of consciousness, fluctuating levels of consciousness. We heard about it earlier today, like delirium. Think about somebody that gets whacked over the head and has trauma and is unconscious because of that, and then may or may not slowly recover consciousness. Or on the other hand, somebody, we heard about this as well, with delayed cerebral ischemia of vasospasm that initially actually looked quite good and then loses consciousness. All of that you have to disentangle when you encounter a patient at different points in time in the intensive care unit. Families demand guidance from us. So they often want to hear, so what's the prognosis? What's going to be the outcome? And I can tell you when I first started, more than 2 decades ago in this field, physicians were much more comfortable to just say, never is going to have a chance to recover. And it's just not actually very accurate. We often don't know whether a patient can recover. If you look at patients with trauma and or other disorders of consciousness with acute brain injury, more than 70% of the patients die from withdrawal of life support. So not because we can't help the patient to survive, but because we sit down with the family and say, you know, there's no hope for recovery. That's great if we're very accurate in predicting recovery, but if we're not, then that's actually a problem. And so I think that's what the talk will be a bit about today. If you ask families what they base their decision to withdraw care on, actually being conscious or having the potential to recover consciousness weighs heavily in that decision. Down here are 3 etiologies that I frequently see in the ICU: subarachnoid hemorrhage, ICH, and cardiac arrest. And you can see that these are cohorts that were all unconscious when they first came into the ICU. Some patients recover consciousness, some patients die. These are 30 days after the injury, but a significant number of them remain unconscious. In cardiac arrest, it's the smallest group, probably not necessarily because the disease is different, but because we're much more comfortable to withdraw care than, for example, in traumatic brain injury. So what does the prognostication depend on? Not everybody recovers. That's important to state. It's not just about giving everybody a chance and everybody will recover. That's clearly wrong. But there is very delayed recovery now seen. And I want to draw your attention to this here. Actually, if you look at patients with trauma, which typically have the best long-term recovery, if you have patients that leave the hospital unconscious and then recover consciousness by a year later, 50% of those patients have at least daytime independence at home, and 22% return to work. So there is a potential also for very high-level recovery. What does the potential depend on? So age does play a role. The older you are, the worse your outcome will be. Comorbidities, environment, the mechanism, location, and extent of the injury, the time to the treatment and the time from the injury, and the best neurological examination. But our prognostications at this point in time are inaccurate. Our behavioral assessment is relatively standardized. We use most frequently throughout the world, the GCS is used. That was not developed to assess consciousness. The 4 score, also mentioned today, is a modernization of that, integrates a bit better like respiratory patterns and some more brainstem findings, but none of these assess consciousness. The best scale to do that is the Coma Recovery Scale Revised. It's a very detailed, structured scale that goes through different components of consciousness, looks at verbal components and auditory, all sorts of different subscales, but it may be quite cumbersome to assess. So if somebody is not completely out and not completely conscious, these in-between states that are most important to identify, it may actually take a bit to assess them, up to 45 minutes. So it's not really practical in a clinical setting, but there's an abbreviation, a more sort of ICU sort of targeted version that is being developed and should be coming out soon. I'll talk a bit now about how can we go beyond your behavioral assessment. So is there anything that's available that we can use to make this more accurate, your assessment of behavior and of consciousness, to hopefully be more accurately predicting. There's different categories. You can think about resting measures, and this is all from the perspective of the brain. So the brain is at rest. For example, structural imaging, CT, MRI falls into that category. Or also we've heard about that surface or depth EEG at rest. Then there's perturbation tasks. One is passive. So you expose the brain to a passive stimulus, for example, an electrical stimulus, like in evoked potentials. And then you see how that's processed in the brain. That can be used. There's also perturbation tasks that are active. So you ask the patient to do something, and you don't watch for what they behaviorally do because they're not doing anything, they're in a coma, but you record a signal, for example, with functional MRI or functional EEG, and then you determine whether there's a signal that distinguishes consciousness. And then there's response to interventions like amantadine, for example. So let's start with resting EEG. So we can look at the EEG, and we talked about this earlier today, just the EEG waves, but they can be processed. And I won't go into all the details, but one thing you can do, for example, you can take the EEG waves, you can break them down into different frequencies, fast and slow frequencies, and then you can look at the power in these frequency ranges. It's called a fast Fourier transform. And so if you look at patients, a group of patients that are conscious, these are patients with subarachnoid hemorrhage, these acutely after the injury, and this is a different group of patients with mostly TBI in the chronic state. And you can look at the spatial distribution of this power. So yellow, for example, indicates higher power, the blue indicates lower power. And without even doing statistics, you can see that unconscious patients versus conscious patients have different power, right? There's also more complexity. So entropy looks at complexity of the signal. The signal is much more complex in the EEG if you are conscious versus unconscious. The interesting thing is this was done in acute patients with subarachnoid hemorrhage. If you compare it to chronic disorders of consciousness, TBI patients, the signals look actually quite similar. So is there something that's more generalizable about what we're detecting there that is more sort of entrained with consciousness rather than the disease process? What was interesting is this group, just to sort of superficially go into this, took all of the EEG that they recorded, all of these quantitative EEG parameters, complexity of the signal, power of the signal, and put it into a machine learning program. You heard about this briefly earlier today, where basically the program learns what the signature looks like. They trained the machine learning program on part of the data and then predicted what the clinical state of the patient was. Was the patient conscious or not? And so they confirmed sort of that because they also could examine the patients. When they did that, the machine learning algorithm with this sort of learned signature of the EEG performed quite well, interestingly, in patients that clinically, so when you went to the bedside, they were in a vegetative state, showed no sort of indication of consciousness, the algorithm categorized a third of the patients wrong and said, I think there's really some consciousness here. But when you examined the patients, in a third of the patients, they were actually not conscious. What was interesting is when they followed these patients up, the patients that were misclassified as conscious at the time, later on, were much more likely to recover consciousness. So what that means is that potentially this EEG algorithm, this machine learning algorithm, detected something in the EEG that behaviorally you couldn't examine, you couldn't detect from your examination. So briefly about MRI. So MRI looks at structure of the brain. Both of these approaches have advantages and disadvantages, but looking at that, you can also look at what kind of lesion causes consciousness. And this paper is a really nice paper where they looked at lesion maps and found that certain lesions in the brain were more likely to be associated with unconsciousness versus consciousness. Next, I'll talk about active perturbation tasks. So that's the approach where you have a patient, they are clinically unconscious, but you ask them to do something or think about something. So this whole field, this whole area was started by a paper by Adrian Owen. and that he published in Science, where he had a woman that had suffered from a traumatic brain injury 6 months before. And she was in this vegetative state. She didn't respond to any commands. She didn't show any level of consciousness to the examiners. And he put her into an fMRI scanner, which basically visualizes blood flow in the brain, and that is linked to neuronal function. And he asked her to imagine playing tennis. And then he recorded that, looked at the blood flow activation map. Then he asked her to imagine walking through your apartment. So this is like, imagine walking from one room to another, and that requires quite a bit of like a spatial navigation task, whereas the first task is mostly about moving your arm and playing tennis, completely different areas of the brain. What was interesting is that this woman, even though she didn't have any external signs of consciousness, activated the same areas of the brain as a group of healthy volunteers. So this went like a shock through the scientific world, also was criticized. What does consciousness really mean? And I won't go into the details of that, but I'll sort of take the story a bit further. So Nico Schiff's group at Cornell showed that you can also do this with EEG. So they used actually basically the similar questions and found that patients could be identified that were actually conscious, even though behaviorally they didn't express consciousness. And so I read this a couple of years ago and then thought I'll do a prospective study. And we looked at a cohort of patients with different kinds of brain injury, a bit more than 100 patients, and enrolled them and just used regular EEG that we use in the ICU to detect seizures. It's our regular cheap EEG. It's a digital EEG. And we exposed these patients to a motor command. What does that mean? We had single-use headphones on, and we asked the patient, move your right hand, and then keep moving opening and closing your right hand. And then we said, stop opening and closing your right hand. And we did this over and over and over again, and switched sides and created a large data set for each patient. And then we took the EEG, clipped these episodes of EEG after the command ended, and put it into basically first a power spectral density analysis, which is exactly what I talked to you about before. You look at fast frequencies, slow frequencies, and you look at how much power there is. And then we recorded that for each electrode and put this data into a machine learning algorithm that identifies whether your response in the brain systematically is different to the move command versus the stop move command. And there's tons of sort of verification steps to make sure that you're not detecting noise. And what we found was that here you can see the controls. So there you can see the move, stop move command. They nicely go up and down. The non-CMD patients fluctuate around the baseline. And the patients that have this phenomenon called cognitive motor dissociation, so the motor exam is much worse than the cognition. They actually fluctuate similarly to the controls. It's much less of an activation, and that is probably due to the fact that they're distracted by all sorts of things. All of you work in ICU, or many of you work in the ICU setting. There's beeping noises everywhere. They probably have pain in the back, so they're more distracted, but they follow the same activation. What was most interesting is that these patients that had cognitive motor dissociation, when compared to the non-cognitive motor dissociation, were more likely to clinically recover consciousness while in the hospital. So half of them did that before they were discharged, whereas only a quarter of the ones without CMD. And then even more important was the functional recovery a year later. So you can see here that almost half of the CMD patients had recovered to the predefined threshold of a Glasgow outcome scale is extended of above 3, which means that you can be left alone for at least 8 hours in a day, whereas only 14% had recovered to that level without CMD. How does this recovery look over time? So if you look at the trajectory, this is actually the shift analysis, and you can see that at all points in time, the CMD patients had recovered to a better state, right? So does this detect a transitory state where patients are on the road to recovery, but they can't show that yet? That's what we think right now. Likely, there's a lot of different phenotypes of patients. One patient is on this trajectory, another one on that. And that will probably make this much more accurate. But we can see that those CMD patients recover earlier and better than the patients that don't have CMD. So when we think about the paradigm that I introduced in the beginning, you can think about that patients with CMD can come out of the minimally conscious minus vegetative state or comatose state. They go into CMD and have a higher chance of recovery. There's advantages and disadvantages of the rest versus the active task. Both need to be considered. So rest can only imply consciousness. It cannot prove consciousness, whereas the active tasks can do that. There's questions about generalizability of the models in the resting state. However, Engelmann and colleagues and Benjamin Rohout and Lionel Nakache in Paris actually developed ways where they can actually show the model that was developed in Paris applied to a data set from Liège was actually also quite predictive. So there's some work going on in that field. With the active tasks, you have to be very careful that you're not detecting artifact. So if you just have a big, long exposure of a task, ask them move, and then you say stop moving, you can actually detect if there's some random artifact that comes in the middle of it and then goes away, that patient could look like they're actually responding to your stimulus. So one of the solutions to that is what I showed you before. It's a block design. You ask them move, stop, move, stop, move, and randomly sort of shuffle that so that it's not always the same distance. And that allows you to make it much less probable that an artifact is detected. Ultimately, we want to go from mechanism to treatment. So the ideal, the goal would be that we identify where is the circuitry broken, what's basically wire in a way, if you want, is not working anymore in the brain, right? And then based on that, select from a large number of possible therapies to support the recovery, not just to detect and predict, but to support recovery. There's medication approaches that you can think about, like amantadine. There's stimulation approaches, electrical, for example, or mechanical, like with ultrasound. There's many different areas that are being explored at the moment. So if we can have high-resolution structural imaging, these are DTI images, you can potentially identify that you can see here, there's much less connectivity here in the comatose patient compared to the non-comatose patient. And here are this is a very nice review by Thibault and looking at all of the different treatment possibilities that we have at this time. There's very important ethical considerations to be taken into account. Currently, the most important ethical consideration is that our current practice is probably unethical. We don't know who's going to recover, but we pretend that we actually know and share that with a family. So that's the biggest, in my mind, ethical consideration. Another ethical consideration is, of course, if you have a very fancy way of predicting who's going to recover, you're going to have to make sure that everybody can use that. And you don't have just something that is in some high-tech center gets developed and cannot be sort of broadly distributed. So one of the important things in my mind, what I always try to do is to make this as cheap as possible and as much built on existing technology. So we actually published our code with the New England paper, and we used only stuff that was actually available already in the ICU. So we used just our regular EEG and sort of conceptualized the stimulation device where we put the headphones on. So all of that is actually relatively cheap and probably extrapolated. Why study consciousness in critical care? Again, we have a knowledge gap, high prevalence, and the impact is huge, right? So the future, we have to define the language. There's ongoing efforts to develop common data elements so that we actually talk about the same thing when we compare studies with Coma. At the moment, it's a huge mess. Every study uses different terminology. We have to understand the mechanism of CMD to then go to interventional trials and have targeted therapies that actually work for these patients. We always have to think about resource-limited settings. The vast majority of patients with disorders of consciousness are actually not in highly technologized countries. They're actually in countries where there's huge degrees of TBI, for example, in the developing world, for example. And then brain-computer interface, I didn't get a chance to talk about that, but we and others have developed technologies where you can start to connect to these patients again, potentially. That's still in the development stage. So the roadmap for the future, I want to just highlight the Curing Coma campaign. I know I ran over time, but there's a huge international effort underway. And actually, everybody is invited. This is not just neurointensive. This is not about neurocritical care, but it was just sort of started by the Neurocritical Care Society. And I really want to invite any person that sees patients with coma to sort of join this campaign. There's like tons of working groups. There's tons of efforts where you can actually become active in this initiative. So ongoing, there's like a supplement that was just published a couple of weeks ago that sort of conceptualized or captures where we are with the campaign at the moment. There's a couple of nice papers there, but it's really time for everybody to get involved, hopefully, and move this field forward. And that's the team I work with in New York, and I apologize that I went over time.